Hi friends, back with another session here. This is a second part of our video, like second question. First one is a carbohydrate metabolism in pregnancy. Now this one is a preconceptional counseling in GDM, which is gestational diabetes mellitus. So what is preconceptional counseling? Preconception, by the name it suggests that before conception, whatever care and counseling we advise to improve the pregnancy outcome. So it is a care and counseling about pregnancy, its course and outcome well before the time of actual conception. It is to optimize the maternal and fetal outcomes in the future pregnancies. And the key components of counseling we will discuss here, including all the strict control of glucose, reduction of the weight, medication reviews, all we will discuss. So importance of glycemic control, consistent blood glucose monitoring to maintain euglycemia, encourage lifestyle changes including the diet and exercise to support the optimal glycemic control. Target levels we have to achieve in the fasting blood sugar less than 95 mg per dl, 1 RPP postprandial sugar less than 140 mg per dl, 2 is less than 120, HbA1c less than 6 or 6.5, average capillary blood glucose level less than 100 mg per dl. Now achieving this is very important before conception just to reduce the risk of miscarriage and congenital anomalies and other complications related to the GDM. After advising the strict glucose control to the patient, we have to advise risk assessment. We have to assess this, if there is any previous pregnancy, any GDM or macrosomia associated with that, or we will screen for comorbidities, obesity, dyslipidemia, hypertension, or BMI management. We have to do screen for complication because obesity is associated with the GDM. So lifestyle modification, nutritional counseling, exercise recommendation we have to give to the patients. In nutritional counseling, we have to advise the patient balanced meal, balanced carbohydrate intake, low glycemic index foods, and a portion control. We have to design a plate for the patient. Exercise recommendation, at least 30 minutes per day, 5 days per week of moderate intensity unless contraindicated. Medication review, in which we have to review the medications which the patient is taking, which is not teratogenic, which should be not teratogenic, and should not affect her pregnancy in any way. So consider starting folic acid supplementation to reduce the neural tube defects and assess current medications to ensure they are safe in pregnancy. Example, transition from OHA, oral hyperglycemic agent, to insulin if needed. So here next point will be risk of reoccurrence and prevention. Educate the patient about the increased risk of a recurrent GDM in future pregnancies and discuss the strategies to minimize its reoccurrence. Now the contraception advice is recommended effective contraception until the optimal glycemic control is achieved. So in a preconceptional counseling in GDM, overall we have to keep a strict glucose monitoring, risk assessment of the patient, like what are the risks, what we have to change, like BMI management and all, lifestyle modification, medication reviews, we have to change the medications which are not safe during pregnancy, followed by the risk of reoccurrence and prevention, which we can advise the patient, and contraception advice. Thank you.